Okay, I think sign-ons are slowing down. So we'll go ahead and get started. Liz, if you're able to pull up the slides. Perfect. So again, hello and welcome to Innovations in Produce Prescriptions, part of the Food is Medicine Technical Assistance webinar series from Food is Medicine Massachusetts, our statewide coalition here in Massachusetts dedicated to advancing the integration of nutrition interventions into the healthcare system. The purpose of this series is really to hear from experts on the ground in Massachusetts, as well as across the nation, regarding issues at the forefront of the food as medicine field. Next slide. Before we begin, I'd like to cover just a few brief housekeeping items. First, by way of introduction, my name is Katie Garfield. I'm a clinical instructor and the director of whole person care at the Center for Health Law and Policy Innovation of Harvard Law School and a co-convener of FIMMA. For this webinar, I would just like to note that we'll be using the Q&A feature. We've deliberately left some time for Q&A at the close of the webinar, so we hope to be able to answer many of your questions. So please use that feature as your questions come up. Second, we will be recording this event. The recording will be made available to all registrants following the webinar. The recording will also be posted on FIMMA's website at foodismedicinema.org. With those points in mind, let's now turn to the substance of today's event. Next slide. To begin, I want to do a little bit of level setting by reminding everyone on the call today why we're here and why we're interested in this topic. And that's really beginning with the question of why should healthcare be thinking about nutrition? And what role do produce prescriptions play in our response to issues such as diet-related illness, healthcare costs, and health outcomes across the United States? First, access to affordable, healthy food is fundamental to health and well-being. Without that access, individuals face a greater risk of diet-related disease, increased healthcare costs, and death. To put this in perspective, consider the following. Diet quality is the #1 risk factor for death in the United States, surpassing even tobacco use. And access to healthy foods plays a critical role in determining health outcomes and costs. Food insecurity, or a lack of consistent access to enough food for an active, healthy life, is associated with an increased risk of a range of serious chronic illnesses, such as hypertension, stroke, cancer, and diabetes. As a result, researchers estimate that food insecurity results in $52.8 billion in excess healthcare costs each year, and that includes $1.9 billion in Massachusetts alone. These trends have serious implications not only for health quality and costs, but also for efforts to advance equity in the US healthcare and food systems. Like many other issues, trends in food insecurity and diet-related disease have been impacted by systemic discrimination, resulting in a disproportionate impact on individuals who are Black, Indigenous, and people of color. Given these connections between food, health, and equity, we know that many stakeholders across the healthcare system are seeing growing urgency to better connect patients to responsive services. So next slide. This slide represents the range of responsive services that are available both here in Massachusetts and across the country. We know that for many individuals, a great deal can be done to address these trends by simply connecting them to basic food access resources, such as SNAP and food pantries. These services are therefore a fundamental foundation in this space. However, for many individuals living with or at risk for serious diet-related chronic illnesses, these services may not be sufficient to fully treat or prevent the onset of disease. This is why we've seen over the last decade the development of a range of food as medicine interventions. These are interventions that specifically respond to the critical link between nutrition and chronic illness. Today, we'll be focused on one specific intervention, produce prescriptions, which live within the broader category that we here in Massachusetts describe as nutritious food referrals. So next slide. So what is a produce prescription? On this slide, you see the definition created by the National Produce Prescription Collaborative. And I'll note that produce prescription models vary across the country, but as you can see from this definition, they tend to all share some fundamental elements. They are a treatment/preventive service provided to individuals living with or at risk for diet-related illness and who have difficulty accessing the foods they need to improve health. Typically, the prescription itself takes the form of a voucher or restricted debit card that a patient can then take and redeem for fruits and vegetables to address that need. Next slide. And importantly, the research behind produce prescriptions is growing. As of the publication of the Food as Medicine Research Action Plan, which you see pictured here, this past spring, there were 27 peer-reviewed studies in this field. And those articles are extremely diverse in the program models and scope that they cover, in many ways reflecting the diversity of approaches that we see across this field. But a couple of key trends are emerging. I will say that research fairly consistently shows that produce prescriptions can improve food security and diet quality. Given the huge impact these two issues have on health, this in itself is a huge win. And I think many people in the country would say, hey, we can stop there. That is a big win. Let's go forward with this intervention. But there is also some initial research emerging beyond those points to even more specifically look at impact on health outcomes and specific biometrics. And here we're seeing some promising results, especially around HbA1c for individuals living with diabetes, with 3 out of 4 studies in a recent systematic review showing a significant impact. And we're also seeing some initial success in addressing issues like hypertension and BMI, though those results are more varied and preliminary. And I will also highlight that there are more studies forthcoming, importantly, including some larger scale studies that we hope to see in the near future. So we're going to learn even more about this important intervention over the next few years. And I'd like to say that that expansion of research is really indicative of the overall growth in this field. Over the last 10 years, we've seen some major steps forward. According to a recent field scan, close to 100 produce prescription programs are operating across the United States. Furthermore, we've seen development of a national coalition dedicated to these interventions, which you'll hear more about later today. And we've seen millions of dollars in federal spending dedicated to supporting and evaluating these programs through the Farm Bill's Gus-Schumacher Nutrition Incentive Program. And of course, most recently, we've seen increasing access to produce prescriptions and other food as medicine interventions lifted up as a priority in the White House Conference on Hunger, Nutrition, and Health. Next slide. And so I'm very excited about today's session and our panelists. We will hear 2 presentations highlighting some of those advancements and innovations in the field of produce prescriptions. These presentations will be followed by a panel discussion with our speakers. First, we'll be hearing from Adam Shyevitch, Chief Program Officer of About Fresh, one of the leading produce prescription programs here in Massachusetts, and a member of the steering committee for the National Produce Prescription Collaborative. A bit more about Adam. As I mentioned, he's the Chief Program Officer at About Fresh, which leverages food retail technology and community-driven advocacy to make sure that everyone has the food they need to be at their best. He works with healthcare payers and providers nationwide to improve food access as a standard part of quality care and assess the impact of such initiatives on diverse healthcare outcomes. Adam has over 20 years experience addressing the non-medical drivers of health, including previous work designing patient screening and referral workflows, developing affordable housing, and leading public-private partnerships to improve public services. After that, we'll hear from Mollie van Lieu, Vice President of Nutrition and Health for International Fresh Produce Association, who, like Adam, is a member of the steering committee for the National Produce Prescription Collaborative. As I mentioned, Mollie currently serves as Vice President of Nutrition and Health for the International Fresh Produce Association, the largest and most diverse trade association representing the full global fresh produce supply chain. Her work primarily revolves around increasing Americans' consumption of fruits and vegetables through federal policies and programs. Mollie previously worked on nutrition, health, and education policy issues at the Pew Charitable Trusts and on Capitol Hill. And so without further ado, I'd like to turn things over to our panelists for their presentations, starting with Adam.
Hi, everyone. Thank you all for attending, and thanks so much to FIMMA for hosting this webinar. I'm really excited to have this opportunity to share our experience with FreshConnect with the broader community and to hear back through the Q&A session some of their interests in learning more. Let's see if I can just advance. I'm trying to advance the slides. They don't seem to be moving. Do I need to? There we go. Okay, so as Katie said, About Fresh is a 9-year-old organization. We actually started off, I'm going to skip ahead here a little bit. We actually started off as a mobile grocer in the Boston area, and we still are. We run 23 markets, mobile grocery markets around the city of Boston that bring fresh, delicious, healthy food to communities throughout the Boston area. In the process of running these markets for many years now, we've had lots of opportunities to work with healthcare providers in Boston. And very shortly after launching Fresh Truck, they approached us for wanting to further underwrite the cost of the fresh produce we sell. And like many other mobile markets around the country, we started off with the paper voucher systems that were cumbersome, didn't generate any data for us or our hospital partners, and were not very dignified for our shoppers to use on a day-to-day basis. So starting about 4 years ago, we began developing the FreshConnect prepaid debit card program. FreshConnect is a true Visa debit card that our healthcare partners can fund with as much money as they want on a monthly basis and prescribe to their patients like they would a medication or a therapy for those patients to go out and purchase the fresh produce they want and need for themselves and their families. From day one, we designed FreshConnect with a couple of core principles in mind. One, we wanted to give our cardholders a powerful, high dignity, high agency tool to use to shop wherever they already like to go shop, to purchase the fresh produce best aligned with their household needs and food culture. And our second driving principle, and both of these are still deep in our DNA every day, is to create a tool that could inspire the healthcare sector to make long-term sustainable investments in food access as a standard part of quality healthcare, not as a kind of sideline benefit or a nice thing to do, but as a true instrument in achieving their healthcare goals, whether that was to improve their healthcare outcomes, reduce their costs, improve their overall patient experience, or improve the healthcare equity that they were delivering. So with that in mind, we've paid a lot of attention to FreshConnect as we develop the program to make it a very streamlined workflow that works very easily with the clinical workflows of our FreshConnect customers, to make the data that we generate with FreshConnect rich and very accessible and very easy to research, especially to combine with claims data or EHR data around healthcare outcomes. And then to build analytic tools within the FreshConnect platform itself that allows us and our partners to do real-time analysis around program outcomes. We currently work in the sort of yellowish states there, Massachusetts, of course, Oregon, West Virginia, and we just launched a partnership in Washington, D.C. In 2023, we'll be expanding nationwide and have partnerships well underway and developing in those kind of orange states you can see. Very exciting opportunities to expand FreshConnect to a much larger array of cardholders and to focus in on specific populations that really, where we think there'll be a dramatic benefit. For example, pregnant women with risk factors, veterans, and other groups in the country that are struggling with food access, and where we think fresh produce can play an instrumental role in helping them and their healthcare providers achieve specific goals. We're able to offer this national opportunity in 2023 because we are riding the rails of our payment processing partner, FIS, the world's largest payment processing organization, and we're getting access to their expansive retail network throughout the country. So our cardholders will be able to shop at many of the most popular supermarket brands around the country, as well as farmers markets and smaller chains that we are absolutely committed to bringing into the FreshConnect network. And for reasons I'll explain in more detail later, there's a strong correlation between the success of FreshConnect and the diversity of the retail network we can provide. Again, going back to our core values of helping people access the shopping options they want to access that are in their neighborhood, that are aligned with their cultures, and that offer them the best products they can buy. So we've picked up a few learnings over the 4 or so years that we've been running Fresh Connect that I want to share, and then I'm going to talk about our learning priorities coming up. First thing I want to highlight is the importance in our experience of simple but deeply integrated metrics. So we use 2 metrics to assess the success of our partnerships with healthcare organizations. First is cardholder activity. So this is simply the percent of cardholders that are shopping in any rolling 30-day period. We track that because obviously for produce prescriptions to work, they need to mimic in many ways medications. They need to be taken regularly. They need to become part of someone's life and part of their household's life. So we want to assure that our cardholders are purchasing that fresh produce almost like a dose of a medication. So every month they're getting $100, $150, $75, whatever the prescribed dose is on their card, they're getting a significant proportion of that every month. The second factor we track, or the second metric we track, is utilization. What percent of that benefit are they using on a month-to-month basis? Again, with the concept of dose in mind, if a healthcare partner is prescribing $100 a month, are they actually purchasing $100 worth of produce, some lower amount? Are they purchasing that amount on a consistent basis? Is it fluctuating significantly from month to month? These are things we also want to pay close attention to, again, so we can offer our healthcare partners and their patients a relatively consistent idea of what dose they are delivering to their patients and what dose, to some extent, those patients are consuming. The other thing that I want to call out is the target that we've set for ourselves for activity and funds utilization. When we started Fresh Connect, we didn't have a lot of comparables in the marketplace to measure ourselves against. So we chose relatively arbitrarily this 80% target, thinking it was a reasonable aspiration. We found out that with the right kind of retail network and the right kind of cardholder support, that 80% is completely achievable. And and we really encourage everyone on the call, as you're thinking about your own produce subscription and how to activate it in the future, whether it's Fresh Connect or somebody else, to use that metric as a benchmark for a quality program. We're currently running between 70 and 75% in our own activity metrics, and slightly below that in utilization. But because we are so focused on these day-to-day, month-to-month metrics, we can continually experiment with different ways to better engage cardholders and keep moving them up towards that 80% target. The other thing that we've learned and are really excited to keep exploring is that higher value stipends increase funds utilization. So this might sound obvious, but in other words, if you put more money on someone's card, from someone's Fresh Connect card, they'll spend more. That's true. But we've also found through, with collaboration with some research partners, that they actually spend a higher percentage of that total value. So they're not just spending more money, they're spending a higher percentage of the value on their card. We think that's really interesting, and we are going to be leaning into learning more about that in the months to come, because we think it has a lot to do with what dosage someone should set, understanding they may not spend all of that money on the card from month to month, but the higher that allotment, the more likely they are to spend more money on the card. So again, something we've already learned and something that we're paying close attention to. But I want to end on this lesson around patient-centeredness. In our experience, as more money comes into the produce prescription and food as medicine world, there are a lot of companies entering the market, for understandable reasons. What we found, though, is that the product we offer, the Fresh Connect card, succeeds certainly because of the retail network that we have access to, but also because of how patient-centered our approach is. We care deeply about the specific impact that Fresh Connect can have on the cardholder. So we invest, of course, in that expanded retail network, but we also invest heavily in what we call inactivity research. Or inactivity outreach, rather. So if a cardholder is underutilizing their benefit, we have a team in place that will reach out to them, and a platform, the Fresh Connect platform, that will alert us to those lower levels of inactivity. And I'll bring up some data in a moment that describes the power of that patient-centeredness. The first I just want to show you a couple tables. This is just the cardholder enrollment that we've seen and how it's increased, especially since January. That kind of hockey stick profile starts in January this year. And that's in direct correlation to the expansion of our retail network. So a number of our healthcare partners were waiting until our retail network became the size it is now. We have about 460 places around the state where people can use their Fresh Connect card. But not only did we get more enrollment, we saw that our cardholder activity profile had a similar kind of hockey stick look to it, where we were seeing about 50 or 60% activity. Now we see again that 70 to 75% activity, with some programs reaching far above that. That's just an average. We have some programs where 95, even 100% of cardholders are active every month. This is what I was getting at with patient-centeredness. So if you look at start looking at that bottom row of columns, these are people that are idle, meaning they haven't shopped with us or using Fresh Connect in 60 days or more. And they have not received any contact from us during that period or from our partners. And you can see that there's a relatively kind of flat line. There is some increase in activity, which is that little green bar at the bottom, but it's modest, and that idle cohort doesn't change all that much. Now compare that to the top rows where people did receive outreach from us or our partners when they had become idle or inactive. You can see there's an incredibly dramatic increase in cardholder activity in the next 30 days. Even after the first 5 days after they are reached, we have a 7 basis point increase in the number of people shopping, and after that it gets all the way up to 46% within the next month. For us, it's just an incredible affirmation of both the investment we've made in cardholder outreach and connection, but just the power of that patient-centered model that we hold so dear as part of our work. So learning priorities. Logistics are really, really important in a produce prescription program. People love to talk about strategy, and strategy is obviously really important. But in my experience, I think generally in our experience in the field, people are under-investing in logistics. It takes a lot of effort to consistently screen and enroll people in a program like this. Often our healthcare partners have to change up their workflows or invent new ones. And that takes a lot of intention, and it takes the right kind of staffing and leadership. And when people take the foot off the gas, it often falters. So I really encourage folks thinking about produce prescription to think deeply about how that screening and enrollment process is going to work. And similarly, what kind of data are partners going to exchange? How are they going to exchange it? And even something as basic as invoicing. How's that going to work? How often do folks need to plan on being invoiced? How much do they need to pay up front? These are things that take a while to figure out, and our most successful partners have invested as much as we have in figuring out those logistical systems in the background. And that's one of the reasons why some of them are so successful. The other is, we talk to our healthcare partners a lot about visualizing the response that they want this program to have. What do they care about? Do they care about biomedical outcomes? Do they care about patient engagement, patient experience, et cetera? It's really important that they identify those goals up front and then get a sense of what probability do they want that they'll see those kinds of outcomes. Some of our healthcare partners are well along the way of thinking through this, and others are just starting to grapple with it. Third, dosage. How much is a healthcare partner going to put on that card, and is that correlated to their results, to their desired response? If they are expecting someone's healthcare to dramatically improve on $25 a month, is that reasonable? If that's all they have available, should they change their expectations about what the response should be for that level of dosage? And also, for how long are they going to enroll people, and how's that correlated with their long-term goals? A lot of funding around this country is structured on 6-month enrollments. In our opinion, that's the bare minimum to have any meaningful effect. And we think that, and we're encouraged by some opportunities for longer enrollments, 12 months, even more, that are more aligned with how many medications are prescribed. So when I write here value, what I'm referring to is, how do we frame the value that produce prescriptions are offering to the healthcare sector? A lot of you on this call, I'm sure, have heard about ROI as a way to measure the value of produce prescriptions or medically tailored meals or other food as medicine interventions. at About Fresh and at Fresh Connect, we think that's a relatively weak way to measure the value these things that produce subscriptions offer to our healthcare partners. We're trying to reframe the conversation around managing healthcare risk. As Katie said early on, diet is the #1 factor, correlation rather, with long-term health outcomes. If healthcare organizations are serious about managing that risk with the tools they have to invest in food. It is the single strongest way to control that risk of cost, negative healthcare outcomes, healthcare inequity. So it's a longer conversation, so I'll just leave that there. And then the last thing I want to point out as a real learning priority for us is figuring out who the right customer for this is. In competitive healthcare markets like Boston, there's a lot of churn. People jump from Medicaid plan to Medicaid plan with some frequency. That minimizes the incentive that anyone has to invest in the long-term healthcare outcomes of a specific patient. That's a real problem because it makes it more difficult to prescribe prescriptions for the long haul. It makes it more difficult for organizations to invest in long-term care and long-term programs. So we're asking ourselves and our partners, like, who's the right customer for this? Is it an individual healthcare organization, an individual insurer? Is it the state? Is it the federal government? Who owns the real long-term benefit that a produce subscription can generate? Again, open question, happy to discuss it more, but it's something we're thinking about a lot. I want to end with just a couple of real successes that have come from our work with Medicaid organizations in particular in Massachusetts. The first of these is just, we've had a chance to develop wonderful habits, and not just us, but our healthcare partners. They've had the chance to develop important habits around screening, referral, and working with patients that are getting produce prescriptions. Those are going to have benefits for years and years to come, regardless of what happens with flex services in Massachusetts or other Medicaid innovations around the country. The second thing is, even though Massachusetts 1115 waiver, which I'm sure many people knows, was just renewed, that those 5 years of additional funding for food access, housing stability, incredibly welcome. It's still just 5 years, but it's modeling financial sustainability, and it's giving Massachusetts and other states the opportunity to think about financial sustainability for produce prescriptions in a deep technical way. And that's very encouraging for me because, again, those habits of practice, those habits of financing are very sticky. And we are encouraged, I'm deeply encouraged by the advances Massachusetts and other states have made in managing the financing around this. And then there's communities with thought and practice. A National Produce Prescription Collaborative is certainly one of them. There are other thought communities around the country thinking about this, talking about produce prescriptions and how best to utilize them in a healthcare setting. And those conversations have been incredibly enriching for us, and I think for everyone participating, whether those are state agencies or practitioners like us, payers, providers, the whole 9 yards. And I look forward to more of those in the years to come. And then, of course, there's all the data that we're generating, others around the country are generating. Some of that data is, about those biometric outcomes and all that's wonderful. But a lot of it is about the things I was referencing earlier. What does a high quality produce prescription program look like? What are its characteristics? What should hospital or payers or the customers for these programs look for in a program? The more that we all understand that, the better we will be served, and or the better our cardholders, our patients will be served, and the more meaningfully we can integrate food into the practice of high quality healthcare. So all of this data is really exciting and powerful. I will end there and look forward to the rest of the conversation. Thank you very much.
Excellent. Thank you, Adam. I think that was a great background and sort of some of the innovations that About Fresh is pushing forward around program design, evaluation, and healthcare partnership. Next, I'm going to turn things over to Mollie Van Lieu, who's going to talk a little bit about another big area of innovation in this field, innovation in policy and across sort of the nation.
Great, thanks, Katie, and good to join with everyone and follow Adam, who gave a really great synopsis, and I always learned something from him. So it's great to follow him. So as Katie said, Mollie Van Lieu, I'm from International Fresh Produce Association. To be clear, we are not implementers of this program. We're really coming at it from a mostly policy perspective. And then, of course, appreciating that produce will be the beneficiary of people eating more fruits and vegetables naturally. So as we think about scaling this, we want to bring together our members and make sure that we are meeting the demand, meeting the need, and just being really engaged and supportive partners. So who are we? There we go. So if you haven't heard of us before, that's totally fair, because we were started at the beginning of this year. Two sister or competitive, depending on who you ask, organizations came together: Produce Marketing Association, PMA, and United Fresh Produce Association, both trade associations. I was with United Fresh for the past 5 years before our new association started. So we represent the full fresh produce supply chain. That's everyone from the seed companies to growers, wholesale distributors, school nutrition directors, big retailers, independent retailers, and food service, and then transportation companies, packaging companies, anybody that has anything to do with getting fresh produce from the ground to the consumer. And while we are the International Fresh Produce Association, most of our companies are US based, but it's a recognition that it is a global industry. So we have that reach as well. So in general, so I work in our government relations department and am focused on nutrition policy. So you could argue that our whole association is focused on increasing consumption of fruits and vegetables, but we look at it very specifically in nutrition policy and federal programs and policies. So historically, that has been the WIC program. So we were really active in getting that standalone cash value voucher that's now a benefit for fruits and vegetables. It's hard to believe that it was before 2009, WIC consumers did not have access to that benefit that allowed them to access the fruits and vegetables of their choice. It was very specific in the types of items that WIC consumers could receive, and the data show that that's been hugely successful, both from a public health perspective and from how WIC families feel about access to fruits and vegetables. And if you've been following that benefit amount has also tripled in the past year, which has been huge. School meals is another area where we play in, specifically in 2010, getting the updated nutrition standards that resulted in doubling the amount and the variety of fruits and vegetables that kids are receiving in schools. So between WIC and school meals, those are really the two main federal nutrition programs that follow the dietary guidelines and are really delivering on both addressing food insecurity and dietary quality, which most of us are referring to as nutrition insecurity or security today. SNAP, we'll talk about that a little bit more. Obviously, the largest federal nutrition program, the ways in which there's many programs like SNAP-Ed that are designed to increase dietary quality through school meals, but the only kind of standalone benefit that we have right now within SNAP is the GusNet program that Katie referenced earlier, and we'll talk about that in a second. We also work on USDA procurement and purchasing programs, which I think there are quite a few food banks on the call today, so I don't need to talk about that too much. But the federal government purchases billions of dollars of domestically produced food for redistribution to food banks and school meals. And for many reasons, and we did not have to get into it today, there's not a lot of fresh produce. They do buy a considerable amount of fruits and vegetables through that program, but not a lot of fresh produce. So we're working on ways in which we can make sure that those low-income consumers also have access to the option of fresh. Dietary guidelines for Americans we work on, as well as effective labeling to help people make better choices. Okay, so why produce prescriptions from our perspective? So Katie went through a lot of the data on kind of healthcare costs, and we're certainly concerned about that. But we're a trade association representing fruits and vegetables, so that's not maybe our number one. We're not like looking out for healthcare insurers, making sure they can drive their costs down. But we certainly, I'm kind of being flippant, but the reality is that 9 out of 10 Americans don't meet the dietary guidelines recommendations for fruits and vegetables. Half of Americans are walking around with diabetes or prediabetes. Half also are at a lifetime risk of cancer. And then 75% are overweight or obese. And to be perfectly honest, we have failed as an industry, and I would argue as a country, at addressing consumption, dietary quality in general, but specifically fruit and vegetable consumption. So it's not something that we as an industry have been able to accomplish on our own. There's many reasons for that in the private market. Fruit and vegetable industry does not have the same amount of money that many of their competitors do. When we talk about advertising, it's very complex as to why people aren't eating and consuming the amount of fruits and vegetables, but that's a big one. We often talk about, well, if we just made it a little bit cheaper and people advertised in the same way that, they advertise junk food, and it's just more complicated than that. Like if I asked you what your favorite brand of onion is, you probably couldn't tell me. If I'm an onion company and I advertise my onion, it may get you to buy an onion, but you're going to go to the grocery store and then buy whatever onion's in there. So marketing alone privately doesn't work. And you also see through time because if you think about what's available in the produce department today versus 20 years ago, 30 years ago, 50 years ago, it means dramatically different. But what often happens with fruits and vegetables is that people kind of change the commodities that they're eating, not necessarily the volume. So iceberg lettuce was king at one point, now romaine's king. So it's not necessarily that people might be eating more, but they're eating a different type of fruits and vegetable. From a policy perspective, the reality is that the resources are really finite in being able to address fruit and vegetable consumption. So the Farm Bill cycles through every 5 years. We're getting ready. Hearings have already started on Capitol Hill on that. And what you'll hear on the Farm Bill is that SNAP is the most expensive portion of it. And that is technically true. I think, it's going to be more than $100 billion with the update to the Thrifty Food Plan and SNAP benefits. And I actually don't love citing that statistic because I think it kind of puts like traditional ag programs against this idea of feeding people. And I don't think it's helpful. But the reality is that it is expensive in terms of this 5-year bill that has to move. And when we talk about what we need to get people more fruits and vegetables and other foods that are good for them, but obviously we're talking about fruits and vegetables today, it's quite expensive to do that. So we have the GusNet program, Double Up Bucks, and I know Massachusetts has been a leader in nutrition incentives. But when you look at federal funding of that, I know some reports are showing that only about 3% of SNAP consumers have access to fruit and vegetable incentive programs. And that is shameful, I think. And I think that it's misrepresented. I think they're often cited as kind of what we're doing to get people more fruits and vegetables. And if you participate in those programs, the data show that it absolutely works. But when it's not available to all SNAP consumers, we're certainly falling short of our goals there. So just purely from a scale perspective, like I would love to think that we'll all be able to, and we being like all stakeholders, be able to come together and make sure that that is a dedicated benefit in the next Farm Bill. Or the next 2 farm bills, when we think about the White House conference goals of solving or ending hunger and reducing diet-related disease by 2030, if we want to do that, we're going to have to, get to getting. And I don't know that it's realistic that we're going to be able to reach a majority of those SNAP consumers. Also, SNAP consumers represent a significant portion of those who are food insecure, but they're not everybody. And this is a problem that goes beyond just the SNAP program and SNAP participants. And I think we put a lot of pressure on the SNAP program to kind of solve everything for us when it's a much broader program. It's reflective of our overall food environment. So that's kind of our thinking from the policy perspective. In moving to healthcare, fruits and vegetables and food in general is much more affordable when you look at healthcare spending. When you're just judging fruits and vegetables and the cost of healthy foods against other foods, they sound and can be more expensive. Although we could have a side conversation about, I think it's a really interesting time right now with inflation. Obviously, food costs have gone up for everything and everyone, but fruits and vegetables haven't gone up quite as much, and it hasn't necessarily translated to increased consumption. So when I was talking a little bit earlier about if we could just make it a little bit cheaper, that doesn't necessarily result in success in terms of achieving these consumption goals. Another thing that we really like about the produce prescription program is another great benefit of following Adam is, once obviously it's a huge amount of work on their end, but from a kind of flow of produce supply chain, it's relatively seamless. So this is something that has huge benefit in increasing consumption, but we're not having to kind of reinvent the wheel from a supply chain perspective. This will look different in communities based on what the communities need. And hopefully it will require an increase in growing in terms of meeting demands and consumption, but in general, it can kind of work through that existing supply chain mechanism. So where are we with produce prescriptions in current federal policy? And I think both Adam and Katie referenced this in some ways, but we have the Medicaid 1115 waivers in certain states. The GusNet produce prescription pilots, the 2018 Farm Bill had the first round of those of $5 million, which is a relatively small amount, although we've gotten really good data already from that. And then just this year, there's an additional $40 million put into the produce prescription pilot, which is basically just a backlog of really great programs that weren't able to be funded with that initial $5 million. Also, really exciting, the VA and Indian Health Service, which are both the only federal, fully federal healthcare systems. We were able, through the coalition, which we'll get to in a second, get report language and appropriations for those entities. And as part of the White House conference, they committed to executing and evaluating produce prescription pilots within those healthcare services. And then the White House conference, we were really excited about through leadership from Massachusetts' own Congressman Chairman McGovern. There was a really significant presence of food as medicine concept with some pathways to get produce prescription a higher priority in federal policy. So I wanted to talk a bit about the National Produce Prescription Collaborative, of which was brought up a couple of times already, because this is a group that really has come together to try to drive what this looks like in federal policy, because we know there's all of these great programs happening around the country. Lots of lessons learned, good data that we still need. And if we really want to have this scale and launch and embedded in the healthcare system, we're going to have to come together and drive that federal policy. So it was first convened in 2020 by Wholesome Wave, which many of you may know. It's a membership-based organization and led by a steering committee. And we also have recent support from Rockefeller Foundation. This is always helpful to me. I always want to know who runs these things. So this is the steering committee. So a few of these folks should look familiar to you. But again, it is a membership association, but these are the steering committee members, a mix of research, policy, and folks who are doing the work on the ground. So again, our mission is to advance federal and state policy change that leverages produce prescriptions as prevention and intervention for diet-related disease, and further embeds this effective model in healthcare and food retail systems. So really kind of pulling together the things that were already said in a lot of what Adam talked about, of making this, convenient to communities and to the end consumer, and embedding this within in the healthcare system. So Katie already shared this is the downside of doing your slides the night before. I wasn't as prepared, so I won't go over the definition again. But again, definitions are hugely important in policy, because if you don't have a consensus around a definition, things kind of fall apart. And naturally, everybody wants to be part of it. So this is what the collaborative came up with for the definition. And then this is our very specific goal. So we are focused on embedding this within the healthcare system. We're really grateful for the support through the Farm Bill, and want to continue to see that, certainly, and the leadership of USDA. But we don't want to get stuck in pilot stage. Which can often happen. So our overall goal is making sure that we can embed this within the healthcare system. And then these are all of, essentially where federal government has, jurisdiction with related to the healthcare system to start. So I hope that gave a decent overview, but I know we want to leave plenty of time for questions. So I will stop there.
Excellent. Thank you, Molly. That was a great overview of sort of where we stand on the policy front. Oh, I see. Did you want to chat through this?
Yeah, I forgot that I had added those. Sorry. And these are all on our website if you just Google NPPC, but these, I won't get into all of them, but if you are interested in the specific federal policy, these are all of the things that we are asking for, that we believe will create, some of the wonkier, but really necessary policy and kind of logistics to make sure that this is successful. Thank you, Katie. Sorry.
Excellent. Thank you. I always appreciate the wonky slide personally, so wanted to make sure you could get that in. So thank you both for really laying that groundwork about sort of what does innovation in produce prescriptions look like on the ground from a programmatic perspective, but also more broadly, sort of where are we going from a policy perspective. So I think that was a great sort of foundation for our panel conversation, which is where we'll turn to next. So I think I want to start again with sort of the elephant in the room, which is the White House conference. So one of the most notable recent wins for produce prescription was the way that produce prescriptions were highlighted at that conference and in the national strategy that was released alongside the conference. So I just would love to start by hearing from both of you your sort of perspective on that day and the strategy. So as a place to start, what were you most excited about in terms of the strategy or the conference as a whole? And whoever wants to take that first is welcome to.
Mollie, go ahead.
Okay, great. So I was I was fortunate that I was able to be there, and there really was wonderful energy in the room. And brought together a lot of folks. And if you've been doing this for a while, there was really great, and not trying to be political at all, but it was kind of the glory days during the early Obama years, where they really gave a platform to nutrition policy. And we've made a lot of inroads since then. But it really created, I think, amongst stakeholders and foundations and community organizations and federal policymakers, it really brought together folks to think about this in a new way, and coming out of COVID with a renewed kind of sense of what this means and what the importance is. But I also think that if we had this conference, it was more than 50 years since, but I think if we had it 5 or 10 years ago, there would not have been the presence of the importance of nutrition and security and even food as medicine. I mean, 10 years ago, that never in a million years would have been part of it. So I thought it was a huge win that you saw that peppered throughout the national strategy. You know, at the end of the day, for the most part, there were some things that the administration has authority to kind of execute on right away. But at the end of the day, it's a paper document unless digital document, unless folks come together and execute it, be it on Capitol Hill, states, foundations, all of those things. So I think that it brought folks together. I also saw a whole of government approach that we don't always see. So there's a lot of great work that's happening, and it's not intentional, but it very easily can happen in silos. So there's all this pressure on USDA to kind of fix this. And then there's all of this great, research happening at NIH, and HHS is doing their thing, and FDA is doing their labeling thing. But you really saw the government come together to think about this holistically. So I think that is a great opportunity, but now it's our responsibility as kind of stakeholders to see that momentum continues.
Absolutely. And I'm going to follow up with you on that in just a second about next steps. But before I do, I want to jump to Adam and see from your perspective, what was most exciting about the strategy or the day? Yeah,
I mean, absolutely affirming everything Mollie said. We also enjoyed being there a tremendous amount, both at the event itself and some of the events that NPPC put on in the following days. I think, I just want to hone in on two things in particular that really jumped out at me from the strategy document itself. The first, I'm going to be very specific here, on page 17, so you can all hold people accountable to this. Paraphrasing the first part, it basically says food as medicine interventions, and this is a quote, can effectively treat or prevent diet-related health conditions and reduce food insecurity. So they're stating that as a fact. So that is a big step forward. It gives us an opportunity to shift the tone and of research from does this work to how should this work? Instead of asking the question of, does this have a place in medicine? How do we find a place for this in medicine? How do we actually implement it? How do we make it a standard part of quality care? The White House strategy document has put a stake in the ground, so to speak, on the efficacy of food as medicine. That is enormously important. Again, especially as a way to hold people accountable, as Mollie said, the next step is to actually do this work. The second thing I want to point out is, Mollie's referencing this a little bit, is this whole society response. There's a section of the strategy called whole society response. And one of its bullet points includes this: states should collaborate with nonprofit or community-based organizations to establish a state-funded produce prescription program. Again, enormously important to put that stake in the ground about the work that should happen now. And especially important to locate that at the level of the state. As I was saying, there's a real question about how to align the benefits or the spending on produce prescriptions with the benefits that accrue to the patient. There's economists talk about wrong pocket problems. The person who spends the money doesn't necessarily receive the benefit of that spending. And that's really an issue in produce prescriptions, especially with all the churn in Medicaid. So to solve for that, again, there's this open question that I referenced earlier: who is the right customer? It may not be the state in all cases, but I really like that the strategy document calls out that a state level response is a goal. That's, again, a very important milestone to achieve at such a high public level.
Thank you both. So I think what I'm hearing, right, is that it was a great moment to build momentum. We were bringing together an array of stakeholders into a room around a movement that might not have even come into the conversation 10 years ago, now taking a pretty prominent role, and then some bold ideas being put forward on how do we go forward in actually making this real. And so I think it was a moment of real momentum building, but I think the big question I have is what next? So if we have this bold strategy that's been released by the federal government, what do you see as sort of key next steps for stakeholders in the wake of this conference? And I'll let Mollie take that first.
So I think it's really important for congressional leaders to hear directly, even if they're your, federal congressional leaders that are doing this work in DC, hearing directly from their communities around why this is needed, if you're doing this work, if you want to do this work, what the barriers are to doing this work, because they have, a million different priorities that come across their desk every single day. And while nobody's going to say that this doesn't have merit to do, they have to make decisions on what they're going to prioritize and what they're going to champion for their states and their constituencies. So unless they hear about this being a demand and fulfilling a need, it'll be hard for them to be leaders on this, right? Because they're going to have other people asking for other things. I almost sound a little Pollyanna with that, but there's really, it's just so important to go in and have those meetings, with staff. It can be in the district or in the state. If you have the capacity to come to DC and do that, that's wonderful too. But I really do think, I'm a huge believer in policy that this stuff, in order to scale, is going to have to happen in DC and at the federal policy level. But in terms of like what actually gets policymakers to do that, it has to start at home.
And I think, for me, and this will come as no surprise, the key next step is practice, practice, practice. And when a new medication comes to market, there's an entire infrastructure set up through FDA to establish its safety, its efficacy, set dosage recommendations or requirements, et cetera. And we don't have that structure. So we have to do that work ourselves. And so that means that, certainly we at About Fresh and Fresh Connect and our peer organizations around the country, I think we need to double down on the opportunity that we have now to figure out like what really works and what can we offer to the healthcare sector in a meaningful way where they can make some sort of predictions about, like, if I spend this amount of money, I'm going to see these kinds of results. Even if those results aren't necessarily purely biomedical. Again, as I was referencing before, does it change patient experience in a very positive way? Does it reduce overall household stress related to food? And as we know, stress levels are an enormous indicator of future healthcare needs or future healthcare outcomes. Excuse me. Does it have follow-on effects for members of the household that may not be the prescribed beneficiary, but nonetheless consuming higher amounts of food? And how do we use it both as a preventative tool and as a disease management tool? So, again, practice, 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 and generate data from that practice and be generous and open with sharing those results. I think we as a sector are only going to advance together. We will win as the opportunity grows for everyone. And certainly that's our attitude. And I know it's the attitude of many of our peer organizations, that we have a lot at stake in our mutual shared success. So that means sharing both the wins and some challenges that we're getting around or that we're dealing with. So again, practice, 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 and generate real tangible data around what it takes to effectively deliver this to patients so it will be consumed regularly and will become a part of their lives as much as we want it to become a part of our healthcare institutions.
Excellent, thank you. And there's actually a question in the Q&A that I feel like connects up to some of the comments that you're just making. And so I wanna ask it to both of you right now, rather than holding it till the end. So Helen in the Q&A writes, it seemed like the healthcare integration options listed in the White House National Strategy focused on reimbursement, but didn't have much about aligning USDA and HHS systems to support bringing the infrastructure for integration, like Fresh Connect platforms and practice level support for systems. Adam talked about needing Fresh Connect to work for practice. Helen asked, am I being overly pessimistic with that read? So I guess I could put this in two sort of concrete questions. One, did the White House conference address the need for infrastructure at all? And if not, what are the needs there and how do we get at them?
Shall I go first, Mollie? Okay. Sure. So I think, frankly, our our attention is focused primarily on the Center for Medicare and Medicaid Services. You know, there's certainly silos, the big silos, Helen, that you pointed out in the federal government between HHS and USDA and others. Right now, we as an organization are focused primarily on breaking down the silos within the silos. You know, getting an organization like CMS to think comprehensively across Medicare and Medicaid about how to integrate food as again, I know it sounds like a broken record, a standard part of quality healthcare, how to fund it, how to evaluate it, how to measure it, you know, just the activity of it. So I don't think you're being pessimistic. I think it's really a question of, you know, what are the primary barriers, what are the first barriers what are the first barriers that we have to address? Are they between those big silos that you pointed out, or are they within an organization like the Center for Medicare and Medicaid Services, which is of course just a subset of HHS? So, you know, again, we're focused very much on CMS, but we're really excited to see some of the work going on in other agencies. We just think the opportunity within CMS alone is so transformative that that's where we're focusing our energy. You know, I know there are peer organizations that are much more focused on USDA, for example, and that's wonderful. But again, I think it's about choosing which barriers we want to address first. And again, for us, CMS is the biggest opportunity to make progress.
I don't think that I have much to add. Adam hit the nail on the head.
Thank you. Next, I want to note, I think we mentioned this earlier, but the strategy, the national strategy places a strong emphasis on Medicaid demonstration waivers as a pathway to fund food as medicine interventions. In fact, the strategy stated the administration plans to launch an initiative and release guidance regarding this option. During the conference itself, importantly, CMS also approved our own waiver extension here in Massachusetts, as well as a waiver extension in Oregon. Our waiver extension in Massachusetts includes the continuation and in some ways expansion of the Flexible Services Program, which is a program in the Massachusetts Medicaid program that allows our accountable care organizations, so our sort of entities of healthcare providers, to use Medicaid dollars to pay for nutrition interventions, including produce prescriptions. So I'll start with Adam. Based on your experience with the Massachusetts demonstration waiver, what would you hope to see in the forthcoming waiver guidance? For example, are there best practices happening on the ground here in Massachusetts you'd like to see lifted up, or gaps that you'd like to see addressed as we sort of move that vision forward at the federal level?
I think you're on mute, Adam.
You're on mute.
It was bound to happen at some point. One of the things I'm really excited about in the Massachusetts waiver is recognizing households as a unit of care, essentially. When the patient is pediatric, or for pregnant women, the produce prescriptions can be, or food as medicine generally, can be prescribed to the household and not just to a specific patient. That's a big step forward because previously we've had to sort of ignore the fact that a household would be consuming this produce prescription benefit and not just the patient, which really complicates understanding that dose and the response that you want to follow from that, you know, investment in someone's food budget. So that's a big step forward. It's related to a gap, however. Even in the Massachusetts waiver, most patients or many patients are being prescribed produce prescription in the context of a household. And even if they aren't pregnant, or even if it's not a pediatric patient, there is a level of household consumption. And if the patient is a caregiver to children or to other adults, it's possible they might even be under consuming that benefit in favor of the people they love and are taking care of. So we still think like it's wonderful progress. We still think there's an opportunity to do more with understanding household consumption of something like a produce prescription benefit. Again, if we're going to take that investment in a certain patient's outcomes very, very seriously. So that's number one. You know, the other thing that I'm looking for in the future, and I don't think the waiver itself gets at this generally, is making it easier for deep research into the healthcare outcomes and costs implications of something like produce prescription. right now, you know, a lot of the beneficiaries or participants in Flex services, their data systems exist at very different levels, and they have a different ability to report on activity, utilization, et cetera. And in part, that's made all the more difficult because there aren't a lot of standards. There aren't really standards in place for the kind of data to collect, how to collect it, and how to share it. It would be great if Massachusetts and other states around the country really put a premium on establishing those data sharing frameworks. So again, the field as a whole could more easily improve. I'm very happy that Massachusetts and other states are investing in infrastructure to support this kind of work, in addition to the benefits that they're providing patients. That infrastructure investment, which came from Massachusetts, was enormously helpful for us. And you know, as it continues, it'll be enormously helpful for others as well to get to a place where they can really do this work. But again, setting those guidelines, whether it's in Massachusetts or nationally, for how to share data and how to learn together, I think would be a big help.
Thank you, Adam. That's great. And I think that a lot of those messages are ones that we've heard across the state here in Massachusetts in response to their experience, those infrastructure dollars being so critical. I know that other states across the country are also now starting to do that. We've seen in California and other states really paying attention to the upfront costs of trying to have these great nutrition programs partner with the healthcare system. So a sort of similar question for you, Mollie, as we think about this 1115 waiver pathway and the forthcoming guidance, do you have any advice for produce prescription programs or their partners on the ground that want to either inform that guidance or support it actually coming out, or even going beyond there, that once we get the guidance, get their states to implement it? So sort of what advice would you give to programs on the ground trying to make this part of the strategy real, the release of that guidance and its utilization?
Yeah. So I'm going to sound like a broken record, but again, I think talking to policymakers and talking about federal policymakers, about the importance of this, because they can do, you know, they have tools. There's obviously like legislation, and that can be kind of a longer play, but there are things that they can have direct conversations with CMS. They can send a letter with their fellow member of Congress or the delegation to CMS to try to encourage these things, and then also facilitate those conversations at the state level with the entities there. So I think, you know, joining with like-minded colleagues in your field is really important, and making this part of, you know, existing coalitions that you might have that might be traditionally anti-hunger, or you know, if you're working with industry. I mean, I think you could talk to anybody about this, but really just elevating the need that is there, and just making sure that your policymakers know that you need them to be a partner in this work too, and for them to utilize their resources and their tools in order to make this happen.
Excellent. I agree with that. Going forth and being heard. Next, I want to jump to a question about some of the key themes that we also heard sort of emerging from the White House conference, as well as I think the broader national conversation in this space right now. So one of the first themes that I think we heard in the White House conference and national strategy is a heavy emphasis on this concept of nutrition security in addition to food insecurity. Can you comment on how that term sort of resonates with you in terms of programming, advocacy, and research related to produce prescriptions? Maybe I'll let Adam take that first.
Sure. Yeah, you know, it's we think about, as I said at the very beginning of my presentation, we think about the role that food has in people's lives a lot at About Fresh and in Fresh Connect, and how to talk about the benefit that quote unquote healthy food can have, you know, both medically and in other ways for the people that benefit from it. You know, so that said, a concept like nutrition security, I think, makes a lot of sense when we're talking to policymakers, when we're talking inside the healthcare world about the specific inputs of a produce prescription towards someone's healthcare outcomes. You know, it's not just that they're buying any sort of food; they're buying nutritionally rich, dense food that has a higher likelihood of advancing their healthcare goals. I think so that's very useful. I think what we have to be careful of is not confusing our sort of inside baseball talk with how we talk to real people that are living full complex lives, and of which food is a obviously essential part. So within Fresh Connect, we talk a lot about the joy of food, the power of food, the power of someone using a Fresh Connect card to take care of themselves and their families, the people they love. And certainly because of the way the card is structured, they're only using it to buy healthy food. So the Fresh Connect sort of takes care of the messaging a little easily. So all that to be said, nutrition security, I think, makes a lot of sense in certain contexts. We just have to make sure that we're not imposing that kind of language necessarily on people that are just interested in feeding themselves and their families a more wholesome, nutritious diet.
Great. And then Mollie, anything to add on that question?
I agree. I mean, I think it, recognizes the ingrained inequities, be they, institutional racism or other disparities that exist within the food system. When you get into food policy, and those of you who've been doing this for a while know this, there's kind of this, sadly, this like tension between kind of public health and anti-hunger. And there's a lot of talk around choice and if people are making good choices or not. And it's like, if you look at our food system, everybody is struggling for the most part with making, I don't want to say making good choices, because we just have a food system that isn't working for most people. But when you talk about low-income people or under-resourced people, there's a reason that we got to this place. And I think nutrition security is helpful from a policy perspective of having a little bit of a reset and saying this isn't about people making bad choices. This is a recognition that we've kind of built a system that's gotten us to this place, and we have to find a way to improve nutrition quality for all Americans, but specifically to address the ways in which we fell short for so long.
Well said.
And I think I'm actually going to build on that a little bit with my next question, which covers a concept that Mollie, you just brought up, which is this idea of equity. I would say another one of the key themes we heard throughout the conference was an emphasis on health equity and the persistent disparities we see in concepts like food security and health outcomes along lines of race, income, and geography. And so can either of you speak to how your organizations and the broader post-prescription movement are working to address those inequities rather than deepening them?
So I can talk about, and this really guides kind of how we're thinking about the future of nutrition security and improving access. So again, like for so long, we've really concentrated on SNAP, but that's just the biggest program that we have in the United States. And we have limited data on that, but publicly available data on that. But what you see, there was a study of SNAP purchases across SNAP and non-SNAP households in one grocery chain over the course of an entire year that the data is like 10 years old now, but it was came out several years ago through USDA. And it showed that, across SNAP and non-SNAP households, you have relatively similar choices in kind of the top 10 foods that people are buying. But when you dig down deeper into the data, you see there's discrepancy for fruits and vegetables. And then when you look at fresh fruits and vegetables, there's a huge disparity. So that tells us that that's a resource problem, not necessarily, again, a choice problem. So how can we find ways to get people access to fruits and vegetables? From a policy perspective, we pursue that through the SNAP program, through GovSNAP. But the reality is that when you live within USDA is tasked with protecting agriculture and food, and particularly American agriculture and food. And that does not always line up neatly with what is best for the consumer. So you know, if we could, as I said earlier, like I would love to see a fruit and vegetable benefit available to every SNAP consumer. To get a meaningful amount, we're probably going to have to spend, you know, at least, let's say $40 a month. When you think, I think the average benefit per person right now is $250. So if you would add $40 to that, that's a lot of money. And there's going to be a lot of other food groups that say, well, we also align with the dietary guidelines. What about us? And then if you represent a state that has another industry that has that presence there, you're going to say, what about that group? So that's kind of a long-winded way of saying, though, that we believe that if you shift this focus into the healthcare system, we can stay consumer focused. And when you stay consumer focused, we're able to address those health equities and health inequities in a way that we haven't been able to do to date.
And that's a really helpful perspective. Thank you, Mollie. And Adam, same question to you. How is About Fresh thinking about the issues of health equity and health disparities?
Yeah. You know, from a practice standpoint, again, you know, what we're focused on is not replicating any of the healthcare inequities that are present in the system. So, you know, we pay a lot of attention to cardholder activity and utilization rates across different demographic groups, and actually just completed our first major study of how Fresh Connect utilization or cardholder activity was different across different demographic groups, and we're pleased to see that there weren't really meaningful differences. So that's step number one. Like, you know, we want to make sure we don't replicate those inequities. You know, part two, and you know, this is more on the downside. We also want to make sure that healthcare organizations aren't using produce restrictions as a way to paper over deeper inequities that have to do with access and other things that are, you know, obviously a tragic part of our healthcare history and reality. In other words, investing in produce restrictions isn't enough. You know, we want to see our healthcare partners thinking about healthcare inequities at a deep systemic level that goes well beyond the produce restrictions that they might offer in their practices. All that said, you know, the number one barrier to accessing fresh produce, fresh food in general, is affordability. You know, there's research shows that consistently. Proximity to healthy food makes a difference. Cultural alignment makes a big difference, but affordability is the single biggest driver. So if we as a society, and certainly as participants in the healthcare sector, are going to, you know, if we're thinking seriously about changing how people access fresh produce and investing in a more equitable healthcare system, investing in people's access to fresh food and increasing their purchasing power for fresh produce is critical.
Great point. And I have my last question on the White House conference, and then I'll go to some broader topics. But one question I wanted to end on that topic is the idea that while the strategy covered a lot of ground, it of course did not address all possible issues. That would be impossible, right? Are there any key gaps in the strategy that you think advocates and stakeholders should continue to focus on moving forward? Maybe I'll throw that to Mollie first.
I would have loved if they said that, you know, we would be cover produce prescription and medically tailored meals or through Medicare and Medicaid, like from the jump, instead of a pathway. But there was a commitment to work with Congress on medically tailored meals specifically. But I think that, again, it was a huge step forward in the right direction, and it created the pathways to do this work. The goal of the White House conference was to end hunger and reduce diet-related disease by 2030. And so 2030 will be here really quickly. And when you do effective food interventions, you can see really quick results, but on a population level, relatively, you know, quick results. But when we think about driving this change on a population level, it's going to take a lot of political courage. It's going to take a lot of resources. So certainly, I think the infrastructure was there, but we just need to make sure that true implementation to reach that 2030 goal is in place and happens.
Hear, hear. And Adam, any gaps that you would want to raise up?
Yeah, similar to Mollie. I'm excited to move beyond the pilot stage in this work and into the policy stage. Like I said at the beginning, our goal is to integrate food and produce prescriptions into the standard practice of quality healthcare across the board: Medicare, Medicaid, private insurance, Indian Health Services, Veterans Administration, and that's of course what we would have liked to see: a real commitment to not just more pilots, which again, great, more practice, wonderful. But pilots, then what? Pilots with a set of let's say milestones that once those pilots are done, we want the healthcare sector to move towards integrating food as medicine within 5 years. Just to pick a number, 3 years, 2 years, that would also be fine. But I think, as Mollie said, it's just getting beyond the pilots and into some commitments.
Absolutely. And I think that's a nice segue into, I want to talk a little bit about research, right? The results that we're getting from those pilots, the experience of doing those pilots, just talking about where we're headed in the research space and its impact. So Mollie, I'll start with you. We've heard a fair amount so far on the sort of current state of research supporting the impact of produce prescriptions. From your experience, what points from research seem to be resonating most with policymakers right now? And are there issues that you think research still needs to address to move the policy needle going forward?
Yeah, so I think that, one shift that we've seen, and we just recently had a policy conference and had some legislative stuff there, is that when we think about fruit and vegetable, for us, it's fruit and vegetable consumption, it had been enough historically to show that programs increase fruit and vegetable consumption. But what we're hearing from policymakers, for a good reason, that they're raising the bar on that and they want to see healthcare outcomes. It's not just about fruit and vegetable consumption. So I think in general, that's a good thing. But we're going to have to be able to produce that data that they need. And that's where when we think about, we've been advocating here today that this really needs to live at HHS and embedded in the healthcare system, but we do have these pilot programs through the Farm Bill at USDA with GusNIP. So making sure that the evaluation and the data coming out of those programs is the data that the policymakers and HHS and health insurers or payers need in order to justify making this true policy.
Yeah, and I think what I'd add to that is I'd like to see a shift in the research from sort of this ROI analysis that a lot of people are making to more like risk mitigation, meaning that they're thinking about populations, not specific patients as much, because I do think that is the way that the healthcare sector is going to get its head around the benefit the prescriptions offer. But more specifically, I would love to see some of these studies extend beyond 6 months. I think the healthcare sector prescribes statins and other medications for a lifetime at the drop of a hat. And until we start thinking about prescriptions and other food as medicine interventions in that same way, we are never going to realize their full benefit, especially on the preventative side. If we think about prescriptions as a true preventative vehicle, it's easy to think about, let's say, pregnant women and reducing prematurity risk, improving infant health outcomes. But those children have a long life ahead of them, and the best way to equip them for success at home, at school, at work, for the future, is to make sure that they're eating well from throughout their lives, from day one and on. So I'd love to see some of these research grants structured as true longitudinal studies, 2 years, 3 years, 4 years. It's a long time to wait for results, But that's the reality of the benefits that produce prescriptions can create, in the same way, again, as many medications are prescribed for a lifetime or for decades. Let's structure the research around prescriptions in a similar way.
Fantastic. And then I would love to then jump, because I know we're getting close to time, to a couple of other quick topics. First, around programmatic challenges in innovation. A question for Adam. To create widespread access to produce prescription services, programs will need to scale their operations. What do you see as the biggest barriers to scaling, and how have you been thinking about those or addressing them at About Fresh?
Yeah, well, certainly the biggest one is funding. You know, at Fresh Connect, we're actually in a great position that scale's very easy. You know, we're currently serving a little over 3,000 cardholders. We could easily grow to 10,000 or 20,000 from an operational standpoint without much strain. I think at least in terms of the card technology itself, I think, you know, operationally, if we are going to maintain our focus on cardholder-centered or patient-centered approaches that involve, you know, calls to cardholders that are maybe inactive or underutilizing their benefit, you know, there's a certain growth that we'll have to go through. But again, I don't think that's the greatest challenge. I do think the greatest single challenge is the constraints on the funding available. The healthcare sector just has to get its head around viewing produce prescriptions and other forms of food as medicine as a long-term investment.
And another sort of programmatic question, this time from Mollie. Unlike some of the other food as medicine interventions, produce prescriptions often require not only a healthcare partner, but also a retail partner, like a grocery store or farmer's market. What do you see as the challenges and opportunities associated with establishing successful partnerships with retailers?
Sure. So this is not always a popular answer depending on kind of what circles you're in. And I think this, again, sound like a broken record, but when we have had so many of our nutrition security and food assistance programs that kind of live in the ag world and at USDA, you have these competing interests, and all of them have merit, right? You want to support small and regional growers and farmers. You want to support local produce. You want to support farmers markets. And those, again, are all super valuable. But if you then want to say it's a public health program, some of those things just don't mesh together. And we have examples of that in GusNIP, where GusNIP started, and when it was FINI and even earlier, as kudos to farmers markets for doing this with nonprofits, started farmers markets. So it's very kind of easy and logical to say this is for local produce. But then when there's a recognition that 90% of SNAP benefits are redeemed at kind of traditional super centers or supermarkets, and there is this push to drive it into grocers where people were shopping, where low-income people were predominantly shopping. When you try to have these kind of same rules of just local produce, you can imagine, like in the produce department or in the freezer aisle or in the canned aisle, if you say you can only have local produce, how complicated that is from a retail perspective of implementing both signage, both with communicating to your cashiers. What happens if someone picks the wrong apple and then they show up and it doesn't qualify? Like, are they ever going to participate again? So as much as we can do on a policy end to streamline implementation for retail is really important, because those are the kind of barriers. And then certainly the technology piece that Adam can talk about much better than I can. But again, if we have the policy in place that incentive, if they know that like we can do this across all of our stores, and the policy is in place there, I think you'll find, retailers will absolutely invest and be willing to do this work. Particularly, I mean, that's larger folks, that's independents, a lot of independents, especially in rural communities. Their competitors are those that don't sell perishable products. So programs like these are hugely beneficial for them. So as much as we can do to kind of streamline and have a really honest conversation about what are the goals of these programs. If we want a program that supports regional production that we should have a program to support regional production, but we shouldn't necessarily call it a public health program if that's what the goal is to do. So yeah, that's my piece on retail.
Can I say one quick thing, because I know we're just at time. You know, some retailers are approaching purchase restrictions as an opportunity to lock in populations that, let's say I'm going to partner with a specific hospital and those patients can only shop at my store. We understand like there's a financial incentive to go that way, but we think there's actually a ton of evidence that giving shoppers choice or giving people choice will be a much more powerful program from a healthcare perspective. I know we're at time, so I'll stop there, but I just want to say that one thing about retailers.
Thank you, Adam. And we are just about at time, so I'm going to do one last sort of lightning round question, and then we'll close out this really great session. So my final question is, as you look forward to the year ahead, what is the one policy change, opportunity, or trend you're most excited about for this work?
I'll go quick. I'll say that the way that Mass Health is proposing to pay for purchase prescriptions in this new waiver is very exciting. It's kind of technical, so I'll spare the details, but it's a big leap forward if we're reading the waiver accurately. And
Mollie?
Very in the weeds, and Adam and Katie know this, but USDA is holding a health equity and health security summit next week, and they're only inviting those in the healthcare sector. And I think that that's a culture shift. So I think that culture is changing in how we're thinking about these programs, and that's a good thing.
Fantastic. Well, thank you both. This has been a fantastic conversation. I really enjoyed it. And as a reminder to all of our audience members, we have recorded this session and we will be making it available to all registrants. And we hope you join us on a future technical assistance webinar. Thank you all.